Well, thanks for having me today. Thanks, Dr. Zabzan and Dr. Banks, for hosting the session. I will talk to you about how deviations from the native slope adversely affect internal-external rotation of a medial stabilized posterior cruciate retaining total knee replacement during flexion. And it's actually going along with the previous presentation, and the title is pretty long, but after the next 6 minutes, you will understand what it means. I also want to thank my co-authors, Dr. Delman, Dr. Howell, and Professor Howell. So I hope I can forward this now. Yes, okay, let's go back. I'm a consultant from Medacta. So in vivo examinations, and as we just heard, determined that based on normal subjects, the rotational pattern of a normal knee is progressive internal rotation with knee flexion. And on the left, you see a graph of the axial rotation of the tibia during knee flexion. On the y-axis is the axial rotation of the tibia, and the negative value is external rotation, positive values is internal rotation. The x-axis is the knee flexion angle, and the range of internal rotation is approximately 15 degrees from 0 degrees to 90 degrees of flexion. And the screw mechanism, which I will explain in the next session, next slide, occurs within the first 30 degrees of flexion. So ideally, and as we just talked about in the previous discussion, restoring the rotational pattern and the range of rotation is the target while you perform a total knee replacement. So what's the screw mechanism that we try to restore? It's the early unlocking of the knee in flexion due to internal rotation of the knee. And it's the locking of the knee due to external rotation at late extension. So how does changing the slope affect the rotational pattern that we just observed? And based on a cadaveric study, the rotational pattern is unchanged by changing the slope. However, the range of internal rotation decreases by increasing the slope. The problem that we're having, and I'm trying to advance the slide now, let's see. The problem that we're having is that even though we are trying to restore the rotational pattern, measuring the internal external rotational pattern during a total knee replacement, I cannot advance the slide right now. Let's see. Now it works. Okay, let's see. So measuring the rotation during a total knee replacement is usually pretty cumbersome and linked to the application of costly navigation. And there's actually little knowledge on how changing slope adversely affects the screw to and the rotational laxity. So the purpose of the present study was to determine first to determine the rotational pattern, the range of rotation, and the rotational positions of the tibial insert on the femoral component at maximum extension and at 90 degrees of flexion. And then to determine how changing the slope might affect the screw mechanism and the rotational laxity. In order to answer these questions, we had to modify our trial components. We use a medial ball and socket component design with a flat lateral insert, and we added a sagittal line on the medial femoral condyle and goniometer markings on the trial tibial insert. To answer the question regarding the slope, we used 3 different slopes, one that preserved the native slope, one that decreased the native slope, and one that increased the slope. We included 21 patients, all were operated with kinematically aligned total knee replacement. Their mean age was 70 years, 9 of them were male. The pre-op Oxford knee score was 21 points, with the worst being 0 and the best being 48. We observed that the insert with the native slope had the greatest internal rotation from maximum extension to 90 degrees of flexion, meaning the greatest range of rotation. And here you see a knee during surgery, and you see the first assist lifts up on the knee, letting the knee passively flex and let the tibia passively rotate. And while the native insert had a range of rotation of 19 degrees, the decreased slope had 4 degrees less of internal rotation, and the increased slope had 5 degrees less of internal rotation. Now the question comes, is the change in range of rotation due to a difference in the position of the tibia on the femur due to maximum extension, or at 90 degrees of flexion? And at maximum extension, all 3 different inserts had a comparable position in external rotation. However, at 90 degrees of flexion, the insert internal rotational position with the native slope was greater than those with the altered slope. Here you can see the knee in flexion. You see the sagittal marking on the femur component and the goniometer markings on the tibial trial insert. And while the native slope had an internal rotated position of approximately 10 degrees, the decreased slope was 2 degrees less internally rotated, and the increased slope was 4 degrees less internally rotated. So in conclusion, the insert goniometer that I just presented to you is an inexpensive, simple, and quite sensitive instrument that measured the rotational position of the medial ball and socket components with a flat lateral tibial insert, and the pattern of internal external rotation of the insert matched the native knee screw hammer mechanism after calibrated kinematically aligned total knee replacement. The pre-arthritic native slope is therefore the target, as deviating from the target by 2 degrees decreases your rotational laxity by 4 degrees. Thank you very much for your attention, and that was it.
Thanks a lot. I think we have time for just one question. In the chat, we have from Dr. Noble. What method did you use to define the posterior slope of the medial tibial condyle?
So we use an intraoperative assessment, and we basically visually match the slope with the angel wing. And then after the resection, we place an osteotome on top of the resection surface, or on top of the articular surface, and then see if the osteotome matches in the slope with the resection surface.